Okay. Welcome again to Living Well. I am so excited that you are here to join us once more for another exciting presentation. Today, before we start, I just want to state our disclaimer. Whatever is said and done here today is for educational purposes only. If you have any concerns or any problems, I advise you that you seek out your professional, your doctor, your physician, or whoever that you're seeing, so to further examine and to help to treat you. So what we do here, we do research, we have experiences that we present to you. So please, anything that you can ask questions at the end, but if you have any concerns, further concerns, please seek your doctor. I am so excited that we have Dr. Anthony Winston. He is going to be presenting to us about colon cancer. This is a subject that we all need to be aware of because colon cancer can be very sneaky, but it's very treatable if we can detect it at an early time. So Dr. Winston, I am so glad that you choose to come here today to present on Living Well. Thank you for coming, and we're excited to hear what you have to say.
All right. Well, thank you so much for the invitation from Dr. Sankey and from Emmeline. This is a topic that's near and dear to my heart. By trade, I am a certified registered nurse anesthesiologist, and I exclusively now work colorectal endoscopic centers across Central Florida, mainly by Florida Hospital South or Advent South at the Center for Digestive Endoscopy. I've been doing endoscopic anesthesia for, oh my goodness, 15 years or so, maybe even a little bit longer than that. So I have a passion for colon cancer, and as Emmeline said, totally treatable if you catch it early. So we're going to talk about some of those things today. I want to thank her for also giving the disclaimer, because that's the start of all of my lectures now. I'm not a medical doctor. This is in no way intended to give you medical advice. And as Emmeline said, I'll be able to answer questions for you, but you need to seek out your primary care physician and your colorectal surgeon or your gastroenterologist for specifics, okay? All right, that being said, we're going to go ahead and get started. I'm going to share my screen. We have a PowerPoint presentation, and embedded in that is also a video that's going to show you what a colonoscopy looks like. So we're going to go ahead and get started, and I'm sharing my screen with you now, and let's go here. All right, here we go. So colorectal cancer, it is the preventable killer. And what do I mean by that is that if you leave your colon alone and you develop colon cancer, you do nothing about it, chances are you're not going to survive. But early detection of colon cancer is the key. We detect it early enough, it is totally treatable. Let's take a look at quickly just a overview of the digestive system. And as you can see here, we start here at the mouth, which is where digestion actually starts. Food enters the mouth, goes over the tongue, down into what we call the food pipe or the esophagus. From the esophagus, it goes into the stomach. All right, the stomach is used to mix food. There are enzymes that are secreted there that helps further break down your food. From there, it passes through something called the pylorus into the small intestine. All right, the small intestine, then it works its way through the small intestine into what we call the large intestine or the colon, okay? From the colon, it traverses up through the ascending colon, through the transverse colon, down the descending colon, finally the rectum, anus, and then out. So if you take a look at the digestive system as a whole, it communicates with the outside on both ends, okay? So communicates here, and then it communicates here. It's not a sterile, there's nothing sterile about the digestive system in no way, shape, or form. And we know that because look at the stuff that we put in our bodies. We know that it's not going to be a sterile environment, okay? We put anything and everything in there. And, the soapbox here is that, we do these things to our body and we expect our bodies to not throw back anything at us in return. And the way God made us, thank God for a wonderful God that we serve. Most of the time when we do that, the body is made in such a way that it protects itself. Okay, but there are times when the body cannot protect itself, and that's when we get ourselves into trouble. So the way to not get into trouble is not to do it in the first place. Okay, all right. So let's talk about cancer itself. So cancer refers to any large number of diseases that are characterized by the development of abnormal cells. Okay? Those abnormal cells then have the ability to uncontrollably divide, and they can infiltrate and they can destroy normal body tissue. When cancer spreads throughout the body, the term for it is called metastasis. So if you've heard of that term, cancer will start in one organ and then it will move to other organs, and that's called metastatic cancer. So it can start anywhere in the body, and anyone and everyone can get cancer. I hear this a lot, and I'm sure those in the health profession have also heard it. Well, you know what? I'm healthy. Surely I can't get cancer. You can't be talking about me. But if you are healthy and you still get cancer, then you probably weren't as healthy as you thought you were. But if you live a healthy life, it can make getting cancer less likely. Now, notice I didn't say by doing this, you're not going to get cancer. I said it can make cancer less likely. There are some things that can increase the risk of cancer. And those are things that some of those things we can't change. And that's like our body's getting older, problems with our DNA that we've inherited from a parent. But there are also things that we can change, and we're going to talk a little bit about that. So most of these gene mutations occur after you're born, and they are not inherited. Okay, those are the ones that we cannot change. A number of forces then can cause some gene mutations, such as smoking, radiation, viruses, cancer-causing chemicals, obesity, hormones, chronic inflammation, and lack of exercise. So when you look at that list, there's so many of those things that we have 100% control over. If we take a look at some statistics on colorectal cancer, the average lifetime risk for men to develop it is 1 in 23. The average lifetime risk for women, 1 in 26. Colorectal cancer is the third most commonly diagnosed cancer in men, prostate and lung being number 1 and number 2. It's also the third most commonly diagnosed cancer in women, behind breast cancer and lung cancer. Colorectal cancer is the third leading cause of cancer death in men and women combined, lung cancer being number 1. If you take a look at these statistics, and these statistics go back a little bit. As a matter of fact, I updated these because I gave this lecture I've asked probably about 3 or 4 times, and these statistics seem to have not changed, but they are current as of 2023. About 150,000 people will be diagnosed with colorectal cancer. Added to this now, because this is the statistic, the statistic that is new, 19,500 of these people that are diagnosed will be younger than the age of 50. About 52,500 people will die from colorectal cancer, and 3,750 of those will be younger than the age of 50. And so why does that become important? Well, it's very important because the criteria for colorectal cancer screening has changed, because we are seeing that people under the age of 50 are starting to be diagnosed at a higher rate. So this chart just looks at the statistics by age, and it tells you who's going to develop it, the percentage males and females, and I can share this, the whole PowerPoint with you if you'd like at the end, and you can take a more in-depth look at this chart. But it pretty much sums up what I said in the previous slide. So if you look at all ages, about 153,000 are going to get colorectal cancer, and the deaths from that, about 52,500. Okay, age of onset of colorectal cancer, and I didn't change this slide. That 2019 should now be 2023. I'm so sorry I didn't update that slide. The rates for people age 55 or over seem to be dropping at about 3.6% per year, and that's good. And the reason that's dropping is because of screening. Okay, now the rate for people under 55 seems to be increasing by about 2% per year, and the reason for that is because of lack of screening. What do I mean by that? That means insurance companies will pay for a screening colonoscopy, or used to pay for screening colonoscopy if you were 50 years and older. unless you had some predisposition to colon cancer, which means first-degree relative who had colon cancer, you have a history of colon polyps in your family, you have inflammatory bowel diseases, some of these other things. But what we have found out is that in the past, I would say, I don't know, definitely within the last 10 years, the incidence of colorectal cancer being detected in people under the age of 50 has increased. As a matter of fact, the new recommendation is that everyone 45 years old now can get a screening colonoscopy. Insurance will pay for that. Lifetime risk of developing colorectal cancer for everyone across the board is about 4.1%. The age of diagnosis for men and women is about 66 years old. Now, African-American men have the highest prevalence of colorectal cancer. So now that becomes very serious, especially for the audience that we have now. Your African-American male, you have a 52 and almost a 53% chance of developing colon or colorectal cancer. African-American women have the second highest prevalence of colorectal cancer at about 38.6%, second only to Native American women. So this becomes a cancer for African Americans, and we should thusly protect ourselves. How does colorectal cancer start? So you'll see the abbreviation CRC, and I might use that instead of saying colorectal cancer. So it usually begins as a non-cancerous growth called a polyp. For those of you who have had your screening colonoscopies or diagnostic colonoscopies and you've had polyps, this is what we're talking about here. So a polyp, it is a non-cancerous growth that develops on the inner lining of the colon or the rectum, and it grows slowly. And this says here on this slide over a period of 10 to 20 years. So it is very slow growing. However, what we always say in medicine and healthcare professionals, you also know what I'm talking about when I say we never say never and we never say always when it comes to medicine. Because I know personally people who will have a colonoscopy this year and next year, they've got more polyps. Okay, so normally they grow slowly, but that's not always the case. So there is a particular type of polyp, which is the most common. It's called an adenoma or an adenomatous polyp. All right, adenoma means that it is non-cancerous. About 1/3 to 1/2 of all individuals will eventually develop one or more of these. I've had currently 4 colonoscopies in my lifetime, and I've been polyp-free until last year, or I'm sorry, my last colonoscopy. So I had one small adenomatous polyp in my rectum a couple of years ago. Although all of the adenomas have the potential to become cancerous, fewer than 10% progress to invasive cancer. Now, a polyp, remember what we said is it's a non-cancerous growth. Polyps are not supposed to be in your colon. So even though they are non-cancerous, when you have a colonoscopy, your endoscopist, your gastroenterologist is going to take those polyps out. Cancerous or non-cancerous, it doesn't matter. The easiest way not to have a polyp grow into cancer is to take the polyp out, okay? And that's what we do in our line of work, okay? So the likelihood that an adenoma will become cancerous increases as it becomes larger. I've worked for some gastroenterologists who, if the polyp is really small, they're like, we'll leave it. We're not going to do anything with it. And I have some other ones that are a whole lot more aggressive in their therapies. If they see even the tiniest polyp, they're going to take it out. And those are the guys that I like. Those are the guys that I want to do my colonoscopies. Cancers arising from the inner lining of the colorectal of the colon and the rectum is called an adenocarcinoma, and about 96% of all colorectal cancers come from these type of polyps. Once cancer forms in the large intestine, it can grow into the wall of the colon or rectum. Now, one thing I want you to understand, or you may have noticed already, is I am limiting my conversation to the colon. Now, remember we looked at our picture, the diagram at the beginning. There is the small intestine, and then there is the large intestine. The large intestine itself is called the colon. The small intestine, cancer very, very, very rarely ever develops in the small intestine. And so screening for the small intestine is very, very difficult. Now, let me tell you another reason why that is. If you had to guess at the length, if you took the small intestine out of the body and you stretched it end to end, how long do you think it would be? And I'll just tell you, it's about 25 feet long. Okay, that's an average of 25 feet long of small intestine that's wrapped around inside of your stomach. That's the large intestine itself is about 6 to 7 feet long. Okay, currently there is no endoscopic procedure. There is no endoscope that will be able to go through the entire small intestine. It doesn't exist. There are ways to test it. We can do something called a video capsule, where you actually swallow a camera in a small pill. And that camera, as it goes through your small intestine, takes pictures. But as I said, chances are you're not going to have a cancer that grows into the small intestine, but definitely will or can in the large intestine. So once that cancer has grown into the wall, it can then penetrate into blood vessels, and it can also be carried in the blood to other organs and tissues in the body. And that's what we call metastasis, okay? All right, this picture shows the different stages of your colon cancers. So at this stage here, or colon polyps, I'm sorry, developing into colon cancer. So here shows just a normal adenomatous polyp, okay? And you can see that right now it's just on the inside surface. This is the inside of the colon right here, and this is on the outside here. So this polyp has not invaded the wall yet, hasn't done anything. In stage 2, you see it starts to go through the wall. Stage 3, even further through the wall. Actually, I got my stages. I think I'm telling you wrong. This is not even a stage. This is just a polyp. This is stage 1, going through the wall. Stage 2, further erodes through the wall. Stage 3, you start to see not only is it going through the wall, but now it's being picked up into some of the lymph nodes and some of the blood vessels. And then in stage 4, not only is it in the lymph nodes and blood vessels, it's being carried to other portions of the body, okay? When we do a colonoscopy, these are the ones that we like to see. These we'll just take out. We'll take them all out, as a matter of fact, as long as it's safe to do so. But these small adenomatous polyps here, they pose no danger whatsoever. But if you leave them alone, they certainly can become these polyps. And you don't want any of these two. These are where the problems begin, okay? All right, so we just talked about these different stages. So stage 1, they've not begun to invade the wall. Stage 2 is called local. It's grown into the wall, but they haven't extended in through the wall into nearby tissue. Stage 3 becomes regional, which means it's gone through the wall, but everything is in a small area around that polyp. And then distant, or stage 4, means that now that cancer has spread to other parts of the body. Liver, lungs, and brain should also be on this also. There are certain signs and symptoms that you should look for when we're talking about colorectal cancer. As that tumor grows, one of the first signs, or one of the easy signs to see, is bleeding or an obstruction in the intestine. So how can you tell this? Well, hopefully, and Dr. Sankey knows that when I talk about this, especially when I'm doing this in an in-person lecture, I normally ask for a show of hands of those who take a look in the toilet once you've had a bowel movement, to see what it looks like. And people may think that that's gross, but I do it every single time. You can detect blood. You can see character or quality of your stool. You know, the stool should have a certain, to put it, I guess simply, it should look a certain way. It should have a certain thickness. It should be a certain roundness. And if it's like that, and you're looking, and then all of a sudden you start to look, and it's now a thin ribbon, then there is a problem. That's something that needs to be addressed, okay? So you can also get anemia, tiredness because of that anemia, excessive fatigue, weakness, sometimes even shortness of breath. We talked about the bleeding that you see when you're finished with your bowel movement and you are cleaning yourself. Take a look at the toilet paper to see if there's blood there. Could be a hemorrhoid that's bleeding, but you can't tell that. It's very hard to determine that. It's much better for you to go see either your primary care, which hopefully your primary care will make a referral to a gastroenterologist, simple flexible sigmoidoscopy or colonoscopy, to try to determine if in fact it is a hemorrhoid or if there's something else. And then we're going to take a look here as we go on. We'll talk about some other ways that colon cancer is detected. All right, so blood in the stool we talked about, and also dark or black stools, okay? Dark black stools normally indicates that there is bleeding somewhere, and if the bleeding is in the rectum itself, then it's going to be bright red bleeding, but if the bleeding is darker, it could be that it's higher up in the colon itself, or it can also be in the stomach, or it could also be in the small intestine. Okay, here we go. We've talked about this, a change in bowel habits or the shape of the stool, cramping and discomfort in your abdomen, an urge to have a bowel movement when you've already had a bowel movement. And that now becomes important sometimes, because now if you have a cancer that is growing in your colon, then that to your body feels like there is stool left in your colon, and your body wants to try to pass that out. And it does not do that, because if it's a cancer that's fixed, you're not going to, you can't pass that out, okay? Constipation or diarrhea that lasts more than a few days. You have a decrease in appetite or an unintentional weight loss, because these cancers, they have to be fed, okay? And if the cancer is being fed, it's taking nutrition away from other body systems, you start to lose weight, you start to lose your appetite. So all of these are symptoms that you should be aware of, and you should seek medical attention if you're having any of these. We're not saying that every time you have these symptoms, it's going to be some type of cancer, but it's better to know than to try to guess. Risk factors that are non-modifiable. We talked about this earlier. Some of us are just going to get colon cancer. All right, so if you have a personal or family history of colorectal cancer, then you have an increased risk of yourself developing colon cancer. A personal or family history of the adenomatous polyps. And remember, the adenomatous polyps are the polyps that are non-cancerous. But if you leave them, they become what we call adenocarcinoma, in which case those are cancerous. Personal history of chronic inflammatory bowel disease over a long period of time. And when we talk about inflammatory bowel disease, the two that we most commonly associate with are ulcerative colitis and Crohn's colitis. So those are the two inflammatory bowel diseases. If you have any history of those things, you should be getting screened even earlier than age 45. And then diabetes is also a, even though, the jury's out on this, because now there are, I'm starting to do some research, and it's not part of this lecture, but I am going to add it to this lecture on how to reverse diabetes. So diabetes itself may not be the non-modifiable risk factor that we thought it was. We're starting to get a better handle on diabetes, and if you can reverse diabetes, then you can ultimately reverse your chance of developing colorectal cancer. Let's talk about some of the modifiable risk factors, and this is the important thing. One, physical activity. Physical activity itself has been shown to reduce the incidence of colorectal cancer, and the reason for that is physical activity reduces it produces hormones. It produces anti-inflammatory mediators, and inflammation has also been shown to be one of the precursors, or one of the things that will increase your chances of developing any type of cancer, and certainly colorectal cancer is included in that. Physically active people are less likely to, or physical active people who develop colorectal cancer are less likely to die from colorectal cancer. And I skipped by the one right above that. Physically active people, 25% less chance of developing colon cancer. So when we talk about being physically active, what do we mean? The American Cancer Society, along with the CDC, recommend that adults engage in at least 150 minutes of moderate intensity activity or 75 minutes of vigorous activity each week. We all have busy schedules. We know that. Sometimes it's hard to even find 10 minutes to do something, but if we can increase our physical activity, we can decrease our chance of developing colorectal cancer. Number two, overweight and obesity. The prevalence of obesity amongst adults in the United States from the ages of 20 to 74 is more than doubled from 15% in 1979, 35% in 2014, 40% in 2023. Excess body weight increases the risk of colorectal cancer, with a stronger association in men than in women, and for colon tumors more than rectal tumors. Obese men have a 50% higher risk of colon cancer and a 20% higher risk of rectal cancer whereas obesity or obese women have about a 20% increase in the risk of colon cancer and a 10% risk of or increased risk of rectal cancer. Overweight and obesity. We need to get our diets under control. These are things that we can modify. Speaking of diet, we need to take a look at what we eat. So it's not, and I want to make sure that you understand that even people who eat healthy foods are not, they still can develop these cancers because too much of anything is still bad. Okay. Calcium. We need to make sure we have calcium in our diet. We need to have high fiber diets. We need to have something called folate in our diets, fruits and vegetables. We try to not eat red meat, processed meat. Got to decrease the consumption of those things. Healthy diets. I wish I could tell you that I had that I have a healthy diet. It's not the healthiest. It's a whole lot better than it used to be. I am diabetic. I've been dealing with diabetes for, I don't know, probably the last 20 years. Strong family history of that, and my father, my grandparents on both sides, I believe. And it's a struggle every day with that. So I'm not going to sit here and chastise anyone because I fall into this category also. But we have to get our diets under control. We have to eat the right amounts of the right foods. Smoking, and hopefully this doesn't affect anybody, but if it does, you need to stop smoking. Smoking is associated with, if you do develop colorectal cancer, your chances of surviving it are lower because of smoking. Alcohol. Now, again, I'm not going to tell you to go out and drink now because, it might be associated with a decreased risk, but the statistics say that moderate and heavy alcohol use, but not light alcohol use, is associated with an increase in colorectal cancer. For me, I'm just going to tell you, avoid alcohol altogether. People who have a lifetime average of 2 to 3 alcoholic drinks per day have about a 20% higher risk of colorectal cancer. Those who consume more than 3 drinks per day have a 40% increase in risk, and the association, once again, is stronger in men than it is in women. So we talked about all of this. Now what? So now you have to be screened. You've detected maybe some of these signs and symptoms, or you're at age 45. Now you need to go get screened. Early detection and removal of these precancerous polyps, these adenomas, is the way to treat or prevent colon cancer. Here are your options for screening. A colonoscopy, gold standard as far as I'm concerned. A colonoscopy or flexible sigmoidoscopy. Now, what's the difference in those two? A colonoscopy looks at the entire colon, whereas a flexible sigmoidoscopy looks at the sigmoid colon and the rectum only. There's also something called the fecal occult stool test. A lot of you, when you see your primary care, they will order this test for you. So you get what's called a stool card, and you follow the instructions, and it detects whether or not there's blood in your stool. Same with the FIT test. They do the same thing. They look for blood in your stool. Cologuard. Cologuard is something that takes a look at DNA, okay? And it will give you a positive or negative indication based on what the DNA says. Now, I will tell you this. A negative FIT test, or negative occult stool test, a negative Cologuard does not mean that you do not have cancer. These things are not 100%, okay? We see it, I can tell you, we see it almost every day. People will come in and they will have done a Cologuard, and a Cologuard comes out negative, and we bring them into procedures because they're having some other symptoms, maybe a little rectal bleeding or something, and they've got full-blown cancer. On the other hand, just because it says that you do have colon cancer doesn't mean that you do have colon cancer. That's why the gold standard is for you have an endoscopist look inside of your colon and look for these things specifically. Okay. Now, I will tell you that Cologuard, they're very expensive. They cost about $600. The fecal occult stool test and the FIT test, they're very inexpensive. So you can use that as a start, but I would not bet the bank on any of those tests. For me, it's going to be a colonoscopy or a flexible sigmoidoscopy. Okay, what I want to share with you now, we'll take a look at, oh my goodness, let me see if that's going to play. I want us to take a look at a actual colonoscopy. I want to see if this is going to play. Just give me 1 second. Let's see if this works. Okay, so it looks like we're not going to be able to do that. Let's get rid of this. That out of there. Let's get this out of here. Let's get rid of all that. Okay, so let me just talk you through it. And I'm hoping that the majority of those who are on the call have already had a colonoscopy. So this is just to rehash some information. So what happens with this is we get you scheduled for your colonoscopy, and you're going to get a couple of calls, and we're going to tell you what to do as far as your prep, what medications we want you to start, which medications we want you to stop. Something that is new, that's coming out new out of, I will say, out of the maybe the last 6 months or so, is that if you are on any of the new weight loss drugs, the weight loss drugs meaning Ozempic, Wegovy, Mounjaro, if any of you are on those medicines, you have to be off of those for a week before any endoscopist will do a colonoscopy on you, okay? So keep that in mind now. It used to be we would just bring you in. If you were on those, it was okay. Now we make you stop those drugs. And the reason for that particular class of drugs is because how they're not only diabetic drugs, but they're also weight loss drugs. How they control weight loss is because they make you feel full longer because they decrease the motility in your stomach and they decrease the motility in your colon. So why would we care about that? Well, from an anesthesia standpoint, if I'm going to put you to sleep to have a procedure, I don't want anything in your stomach because you have what we call an unprotected airway. Contents in your stomach will seem to migrate from your stomach and into your lungs, into your mouth. You'll throw up. We don't want those things to happen. They don't happen all the time, but there's an increased chance of that happening if you have what we call a full stomach. So we want you to be off these particular drugs for at least a week before you come in to see us. And if you're not, we've actually started canceling those cases and rescheduling them until you're off of those drugs for a week, just for safety concerns now. All right, so we'll give you the information. We'll tell you what drugs to take, what drugs not to take. We'll let you know if you need to be cleared by anybody else. So if you have heart problems, you're going to have to see your cardiologist. They're going to have to sign off. If you have a history of neurological problems, strokes, seizures, we're going to ask that you go see your neurologist. If you have major kidney problems, we're going to have you see these other specialists before you come to see us. So now, once that's all taken care of, we're going to order you a prep, some type of prep. It can be something as simple as over-the-counter drug called Miralax and Dulcolax. And then there are also different preps that are prescription only. We're going to ask that you take your prep. We're going to give you instructions on how to do the prep and just follow the instructions that you're given. We want you, by the time you're finished with the prep, to have clear, transparent diarrhea. That's what we're looking for, okay? All these things sound gross, but I mean, this is just the nature of the beast. Clear, transparent diarrhea so that we can actually see inside of your colon. If you're not prepped and you have stool in your colon, there's no way we're going to be able to see polyps. And when we go in and we start the colonoscopy, if we see that, we're going to stop the colonoscopy and we're going to have you re-prep and have you come back, okay? So follow the instructions of your prep. So the day you show up for your procedure, we're going to get a whole bunch of information from you. We're going to put in an intravenous line, and we're going to take you back to the procedure room. Once you get to the procedure room, you're going to have an anesthetist that's going to hook you up to vital signs monitors, put some oxygen in your nose, help you get positioned for your procedure, which 99.9% is going to be on your left side. Once that's done, you've spoken with the doctor, we've taken care of all of the administrative work, you're going to get 2 drugs through your IV. One called lidocaine. Lidocaine is most notably used, or where you would hear from it if you're in a non-medical profession, is when you go to the dentist, they numb your jaw, numb your gums to do your cavities or your root canals or whatever. Same thing, but we're going to give it to you in your vein. And the reason we give that is for two reasons. One is because it blunts your gag and your cough reflex. And number two, it also will decrease the chance of the propofol, which is the drug you're going to get next, from burning when it goes in your vein. Okay. So your actual sedative is a drug called propofol. And yes, it is what people call the Michael Jackson drug. You're going to get propofol. Propofol is a non-narcotic, fast-acting sedative. Once you get a dose of propofol, you will be 100% asleep in less than 20 seconds. The bad thing about propofol is it doesn't last long. So if we're not watching it, and about 3 to 5 minutes, you're going to start to wake up wondering why you're awake while you're still having your colonoscopy. So you'll get propofol as long as your procedure is going on. And again, the good thing about propofol is after your last dose, 3 to 5 minutes, you're starting to wake up. 20 minutes later, the doctor's coming to give you your results and he's sending you home. When they do the colonoscopy, if we find polyps, we take polyps, again, as long as it's safe to do so. If it's not safe to do so, then a recommendation will be made where you might be sent to the hospital to have a colorectal surgeon take them out. If it's a cancerous, then we're going to send you through the whole cancer protocol, which may include having that portion of your colon taken out, having chemo, having radiation. Okay, but remember, this all starts with you coming in for a colonoscopy and us detecting these polyps, non-cancerous polyps, cancerous polyps, or cancer itself. Okay. All right. Okay, I don't want you to play that. All right, here we go. So here are some of the treatments. How am I doing, Emily, on time? Am I good? You're muted. All right, so just give me 10 minutes, 15 minutes. How am I doing? Show me with your hand because your microphone is muted.
Yes, that's fine, Anthony. That's no problem. Sure.
Okay, all right. Yeah. So we're coming close to the end. I wanted to save some time at the end for questions. Sure. Okay, so colorectal cancer treatment. Most people with cancer, as we talked about, may have to have some type of surgery to remove it. Not all of them have to have surgery. Some can be treated with radiation and chemo. But radiation itself is normally not necessarily all that good for colon cancer. So stage 1 cancer, we remove the growth of the abnormal cells by having your colonoscopy, and the actual procedure itself is called a resection of that polyp. And then you may also have to have a resection of the area around it, depending on the size of the polyp, whether or not it's we're able to remove it. We do it by placing, for most polyps that are large, we place a little loop or lasso around that polyp, and we just squeeze that loop and we just pinch that polyp off. If it's too big or there's a chance that you might have some bleeding, then we might apply something to it called cautery or heat so that we burn the actual blood vessels. And if we are concerned about whether or not you're going to have a lot of bleeding, especially if you are taking any type of blood thinner other than a baby aspirin, if you're taking Plavix or you're taking Xarelto or any of these type of blood thinners, then we may opt to put a clip on that area that we take out. So we take the polyp out, we put a metal clip on there. If we do put a metal clip on there, you're going to go home with a card that says you have metal in your body. That becomes important because if you go through airport security, the x-ray scanners, it will show up, okay? And you might need to be able to prove to them that you're not carrying something that's contraband. You actually have a metal clip in your body. Okay, the localized, again, surgical resection, and maybe taking out portion of the colon that is surrounded. That's stage 2. Stage 3, pretty much the same thing, but here you're starting to get to the point where you may have to have chemo because that cancer has started to spread to nearby tissues. And definitely in stage 4, you're going to have some type of chemo radiation along with some type of colon resection. Now, there's a lot of stigma that comes with the colon resections because people are afraid of having a colostomy. Colostomy, just because you have a colostomy now doesn't mean that you necessarily will have it forever. There are also procedures called colostomy reversals. And so you have the colostomy initially to start with, and then the tissue itself, it needs to have time to heal. So you don't want all the stool and stuff to go through the area that you just had surgery on. So you have your colostomy, give the tissue time to heal, and then you have the colostomy reversal and everything goes back to normal. All right. Let's just keep going back. This becomes important now because there are still people out there who refuse to have their colonoscopies, and they're these perceived notions that they've been taught or they're thinking about. One, fear of the procedure itself and bowel preparation. I have lots of patients that come in and they are terrified of going to sleep, and I try to I talk with them and I try to reassure them. And one of the things that I tell them all the time is this fact, that probably in my career as a nurse anesthesiologist, I have probably administered 100 to 120,000 anesthetics in my career. I have personally had 4 colonoscopies and 4 upper endoscopies or EGDs. And I tell the patients, when I'm laying in that bed where you are right now, I'm just as nervous as you are. So it's okay to be nervous. So we accept the fact that they are nervous, and we let them know that that makes them normal. It's okay to be nervous about these things. Fatalism, religious beliefs, lack of self-worth, sexually related concerns, history of sexual abuse, all of these things can make a person not want to come for their colonoscopy. So it's very important that when they see their gastroenterologist, that these things are talked out. And there are some concessions that we in the surgery center side can make. For example, if it's your religious belief that men should not see men should not see the wife's genitalia, then we make sure that we have a female CRNA in the room to take care of that. Now that may not happen with the gastroenterologist, and for whatever reason, the husbands are okay with a male doctor seeing their wife, but not male staff. So we 100% we're okay with that. And if it means that I have to have a female come in and take over my room for that case, then by all means, we want to do whatever we can to make sure that patients get screened. Okay. There are a lot of people out there who don't want to have these colonoscopies because they're afraid of what the outcome is going to be. I see and hear that all the time. So, well, I don't want to know because if it's cancer, what am I going to do? Well, you know what? Those are things that you have to think about also. There's embarrassment. There's, I can't get transportation. It's going to take up too much of my time. And there's also the one that I don't need the procedure done because I'm not having any symptoms. Not all colon cancer is going to produce symptoms. That's why at age 45 come in. We've had people that have come in with no symptoms whatsoever who are already in stage 4 colon cancer. Okay, so you still need to be screened. And also a barrier will be, well, I don't have a family history, so I don't need to have it done. Other barriers, cost, lack of insurance, these are the big ones. And we're so thankful now that insurance companies are stepping up to the plate and going ahead and authorizing everyone that is 45 years and older now to have a screening colonoscopy. So we need to remove the barriers. How do we remove the barriers? One of the ways is, one thing that we talked about already, is to have them do the fecal occult blood test, have them do the FIT or the Cologuards. Not necessarily the most cost effective for the Cologuard, but for them, it may be something that will get them in to have a colonoscopy, especially if they have a positive result. Okay. All right. The Patient Protection and Affordable Care Act helps to reduce the cost of some of these things. So it makes it makes it easier for these patients who may not be able to afford it, to help them to reduce some of the costs of having these procedures. All right, so to wrap it up, colorectal cancer, the 3rd most prevalent and the 3rd most lethal cancer. Screening is the way to detect it. Polypectomies are the way to prevent these things from becoming cancer. Colonoscopy, sigmoidoscopy with polypectomy is the gold standard of preventing these colon cancers. And remember, some patients may not have any symptoms, so you need to come in when you're supposed to come in. If it's 45 years old, come in when you're 45 years old. If the recommendation after you had your colonoscopy is that you come back in 3 years, don't wait 6 years, don't wait 7 years. Come back in 3 years. These polyps will grow. And remember, if you are having symptoms or if you want more information on these, please contact your primary care physician, or if you already have an established gastroenterologist, talk to your gastroenterologist. But seriously, you can help prevent colorectal cancer. Schedule your appointment now. Remember, colon cancer can be prevented. If you need some recommendations on good gastroenterologist, get in contact with me and I will certainly help you find one. I want to thank each and every one of you for your attention today. And this is the end of my formalized presentation. I will take questions now.
Oh, thank you, Dr. Winston. I
You're
was
very
just
welcome.
going I was going to ask. I think you answered at the end. If you find a polyp, since it's slow growing, 10 to 20 years, when should you go back again to have a repeat colonoscopy?
That's a good question. So Emily's question is, you had your colonoscopy, they found a polyp, they took that polyp out. When do you come back? The recommendations right now, depending on, excuse me, once that polyp goes to the lab to be analyzed, depending on what type of polyp it is, it could be 10 years, it could be 5 years, 3 years, could be 1 year, depending on the type of polyp. So for most people who come in for screening colonoscopy and they find absolutely no polyps, the recommendation is 7 to 10 years. There's also, you will also time out by age. Medicare won't pay for them over 80 years old anymore. But that doesn't mean that you cannot have, I'm sorry, Medicare won't pay for a screening colonoscopy over 80 years now. If you're symptomatic, they will most certainly pay for it. But if you're, you've had polyps all the time, and maybe you didn't have a polyp this time and you're 80 years old, I wouldn't wait 10 years. I wouldn't wait. If I'm 80 years old, I'm going to schedule one, even if I have to pay for it, because you just never know. Now, there's also something that you have to consider that I didn't make part of the lecture. So say if you're 90 or 95 years old and you're having a little rectal bleeding and they come in and they find polyps, or let's not even say that they found polyps, just saying you're having these symptoms. So what is your next step? If at 95 years old you have this and they find a polyp or they find something that says that you need to have surgery, these are decisions that you have to think about. Well, you know what? I'm 95 years old. Especially if I'm 95 and I'm not healthy, do I subject myself to a surgical procedure because I'm having these things? And this is not just for colon cancer. This goes for any health issue. There's a risk-benefit ratio that you have to think about. But for a typical colonoscopy, anywhere from 1 to 10 years. I've actually, Emily, seen though, we'll bring them back in 3 months if, say we can't get the whole polyp out, or we're concerned about that area. We might want to go in even earlier, 3 months, to say, hey, listen, I need to go look at that area again. Especially if, when I send that polyp to the lab, it comes back cancerous. We may schedule you to come in because now we want to take a look at the area around where that polyp was to make sure that we got it all out.
Mm-hmm. Okay. Very informative. So at this time, Dr. Winston is open for question. Anyone have any questions?
He didn't finish his statement about if you're 90 or 95 and you went in for symptoms, or if you had it, what you should do at that point, depending on if you're in good health or not.
So the point that I was making there, Linda, is that it becomes a risk-benefit ratio. If you're 95 years old, are you going to subject yourself to a surgical procedure? If you're 95 and you have cardiac problems, or you're in renal failure or whatever, it may not even be a decision that's left up to you. You may not even find a gastroenterologist or I'm sorry, not a gastroenterologist, a colorectal surgeon or an anesthesia provider who's going to take a chance of having that or doing that procedure on you just because of your comorbidities of renal failure or heart problems. So it becomes a quality of life issue, and that's a hard decision to make. I don't know if I ever want to be involved in a situation like that where I have to tell you, well, you know what, I'm going to lay it on the line for you. If I put you to sleep for this procedure, you may not wake up. Is it worth risking your life to have this polyp taken out? You're 95 years old. And again, I'm not trying to give anybody, not me personally, but we're not trying to pronounce a death sentence on everyone or anyone, because it may sound like I'm saying, well, you know, you're 95, you may not live till 96. So why are we going to do this? That's not it at all. Because we know for a fact, you know, in our Christian walk, tomorrow's not guaranteed to anybody. You could get out, you know, leave your house and get hit by a car, hit by a bus. It doesn't matter. But those are some of the things that go into the decision-making process, especially when it comes to insurance companies. Insurance company may not pay for that.
Mm-hmm. You mentioned something about calcium. Do you know why calcium prevents colorectal cancer? Why would calcium?
I believe calcium, I have to look that up. I think it is a precursor to one of the anti-inflammatory pathways. And we know that anti-inflammatories themselves are good at preventing all kinds of cancers.
Right. Yeah. Yeah.
So I think it's the same with folate. I think it's the same with calcium. The fiber was there, and we understand the purpose of fiber, because, you know, insoluble fiber, you know what it does in your body? It does nothing. All it does is cleans your colon.
Like a broom. Yeah.
Just like a broom. Exactly right. So good insoluble fiber, so benefiber, metamucil, that stuff, or you can get good fiber in, you know, all your fruits and some of your fruits and vegetables too.
Yeah, I was kind of puzzled when I heard calcium. I have to look that up because I'm not.
And I'll look it up too, because and I'll add it to this lecture.
Right, that's good to know why calcium. Yeah. I know with COVID we were looking at vitamin D, which also helped with calcium. Because those two, vitamin D and calcium, correlate. So I don't know if the anti-inflammatory process as you were talking about. Yeah.
I'd like to say thank you, Dr. Winston, for sharing this information. I mean, I think in addition to what you mentioned about the screening colonoscopy, is the foods that we eat play such a big role in, you know, our health and our well-being. So making sure that we do incorporate those fibers and fruits and vegetables and exercise and minimizing our stress. All of those things actually affect the body. Sometimes we think it's just one thing, but sometimes it's many things. So I would say keep the colon clean with clean eating. And then the other thing I would say is, you know, keep walking and exercising, because that keeps the regularity of our bowels and our whole system, the entire system working well.
Absolutely. And then let me just add this, Dr. Sankey, is that, you know, Ellen G. White was a very, 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 she was a smart lady, and she was definitely, what's the word I'm looking for? She was, informed is not the word.
Inspired.
Inspired by God.
Yeah.
Because she knew in her writings, and this is in either health ministries or councils on diets and food, that there is a direct correlation between your stomach and your brain. So the things that you eat can influence your thinking. The things that you eat, if you look, there some of the same proteins and enzymes found in the stomach are all over in your brain. So if you affect one, you affect the other. So the things you eat can certainly affect your mood. The things you eat can certainly affect you know, your overall, the way you feel, all controlled by the brain. And this was stuff that Ellen G. White wrote back in the day.
Yeah, so true. Josephine has her hand raised.
Yeah, good afternoon. This is a topic right up my alley, because about 2 weeks ago I had a colonoscopy thanks to Cologuard. And as how all the pictures, probably I can share my experience one of these Saturdays with the group. We found 2 polyps. My last colonoscopy was in 2017. So probably, and it was squeaky clean. So probably I wasn't due until the next 3 years. So I thought I was all right. But I wasn't. Biggest one was 20 millimeters.
Oh, that's a big one.
Yep. And the
Mm.
other one was about 2 or 5 millimeters.
Yeah,
So
that 21 is a big one.
yeah.
Mm.
And that's what you'll see. And a lot of times that will cause, you have polyps that size, the polyps bleed a little bit, and it causes your Cologuard to be positive. So that's a good thing. And remember this, if you have a positive Cologuard, the next thing that you should be doing is having a colonoscopy, because all the Cologuard says is there may be something there that's causing bleeding in your colon. We don't know what it is. Like, you can get a positive Cologuard from other things other than polyps, but the way to find out is to have a colonoscopy. So positive Cologuard, positive FIT test, positive fecal occult blood test. The next thing you need to be doing is having a colonoscopy, because all those things will do is tell you that there's bleeding from something. But in order to find out what it is, you have to have a colonoscopy. So in my mind, that's why I say, well, I might as well, if it's positive, or a chance of it's going to be positive, I might as well just have the colonoscopy and just be done with it.
Mm-hmm.
So what you're saying, sometimes there might not be frank bleeding. You might not see any bleeding in your stool, or or signs that you have bleeding where the stool may be dark in color, tarry looking, and still have some issues going on inside.
Absolutely. Absolutely. The ones that will be most prevalent that you'll see will be those that are lower down. So, you're talking about a rectal polyp or a sigmoid polyp. The ones that are a little bit more elusive are going to be the ones that are higher up. So we're talking about a polyp in the cecum, a polyp in the ascending or transverse colons. Because if those are bleeding a little bit, that blood has a lot of time to be diluted, and you may not ever see it, when you're having a bowel movement.
Mm-hmm.
Yeah, mine was in the area where the large intestines and small intestines joined.
Okay, so yeah, yours is in the cecum. Yeah.
Wow. Very important. This is such a timely message, especially for, for our group, because I think the majority of us are African Americans. So
I wish that there were more African American men on.
Yeah.
We're the ones who don't want to go to have these done. If I look at it, I can tell you my patient population that I see on a daily basis, there are not a whole lot of African American men. There are a lot of African American women. So bravo Zulu to you ladies for coming in and having this done. Talk to your husbands, talk to your sons, talk to your brothers, and get them in to have this done.
Wow.
It is truly a call.
Yeah.
It really truly is a call to action. I think that all of us that are on, if we have not had our colonoscopy, that we take this serious, because it is, as Dr. Winston said, it's preventable. If we catch it early and they remove the polyps, your life after that could be so much better. But if you wait and hesitate and you kind of mull things over in your mind, that's the reason why you won't do it, and you don't have any symptoms, because that's really kind of how people are. If it's not fixed, don't try to break. If it's not broken, don't try to fix it. If they have no symptoms, but that's not true. What you don't know could kill you. It can not only harm you, but it can kill you. So we want to encourage our audience that and thank you, Josephine, for your sharing.
Yes.
Because sometimes we hear someone else say, I've gone and I've done this, and I'm glad I did. And that's exactly the message that we want. And that's why we invited Dr. Winston to come on, because we know that our population tend to be very hesitant about taking care of our health as it relates to our colon. So if you haven't had one, I would just say, let this be your call to action, that now more than ever is a great time to do one. I'll turn it over to Emily.
Okay, so okay, thanks again, Dr. Winston.
You're very welcome.
Very good information. So I'm going to start